Morning, everyone. Myself, Dr. Sagar Makhija, Assistant Professor in Index Medical College from Skin Department. Uh, my today's topic is alopecia areata. So, it's an autoimmune skin disorder, autoimmune skin and hair disorder, in which there is loss of hair. So, there is an autoantigen in the hair bulb, and the immunity acts against it. So it's a non-scarring type of alopecia. So for today's topic, let's start alopecia areata. In this topic, we will include clinical types, introduction, clinical types, clinical features, diagnosis, investigations, and treatment part. So what is alopecia areata? It is a palette. It was first described by Celsus. It's a non-scarring autoimmune inflammatory hair loss on scalp or body. Most commonly, it involves the scalp. Incidence is around 0.1 to 0.2%. It can affect any hairy area of the body, any hairy area. The severity, course, and the prognosis is unpredictable. Positive family history is seen in 10 to 20% of cases. So let's include what is the types and the classification of alopecia areata. The most commonly used classification is Ikeda classification. Scientists Ikeda classified alopecia areata into 4 types. That is the common type, the atopic type, autoimmune type, and the pre-hypertensive type. So alopecia areata is divided into 4 types according to Ikeda. So let's describe in detail. First is the common type. It is seen in around 80% of cases of alopecia areata. Age group affected is around 20 to 40 years. There is no associated other disorders with this alopecia areata, such as thyroid disorder or any autoimmune disorder. The individual patches of hair loss last for less than 6 months. So this can be a self-limiting condition. And the spontaneous regrowth is seen within 3 years. So if the patient doesn't come to know and about patchy hair loss, he can get spontaneous regrowth within a span of 3 years. And this patchy hair loss can develop into alopecia totalis, that is complete hair loss of the scalp in 5 to 15% of cases, which is very severe. Second type is atopic type. It is seen in around 10% of cases. It begins during early childhood or adolescence. So it's a poor prognostic factor. Individual patches last for more than 1 year. Previously, it was less than 6 months. Now it can last for more than 1 year. And in this atopic type, the difficult, or you can say the bad prognostic types, that is ophiasis and reticular pattern, is commonly seen. There is higher chances of developing alopecia totalis, that is around 30 to 75% of the cases. The third type is an autoimmune type seen in around 5% of cases. So it is mainly seen in the middle-aged people. It has a prolonged course of action and duration, can lead to alopecia totalis in 10 to 50% of cases, and it is most commonly associated with type 1 diabetes mellitus and peptic ulcer, Addison disease, etc. The last type is pre-hypertensive type. seen in around 4% of cases. This is seen mainly in young adults whose parents are hypertensive. Parents. It has a fast progression, can lead to alopecia totalis in 40% of cases. The reticular pattern is more commonly seen in pre-hypertensive type. So the pre-hypertensive type and the atopic type can there are higher chances of developing alopecia totalis. After the types, we will start about the etiology of alopecia areata. So there are three main etiology associated with alopecia areata. The first one is hereditary. That is, it has a polygenic inheritance. Multiple traits of multiple genes are involved. HLA associated with HLA DQ1, DQ3, DR4, DR11, A1, and B62. And the chromosomes most commonly involved are 4, 8, 15. The second etiological factor is psychological factors such as stress. So stress is one of the important aggravating factor in alopecia areata. And the third and the most common etiology is autoimmune mechanism because autoimmunity is of two types, cellular and humoral immunity. And clinically, so it is associated with many autoimmune disorders such as Hashimoto thyroiditis, Addison's disease, pernicious anemia, vitiligo, lichen planus, pemphigus foliaceus, and SLE or systemic lupus erythematosus. And the second autoimmune etiology includes humoral immunity, that is antibody mediated. So circulating organ-specific antibodies are found against thyroid, parietal cell of stomach, adrenal tissue, smooth muscles, testes, or ovaries. So such antibodies are responsible for autoimmune disorders like thyroiditis, Addison's disease, or pernicious anemia. Now, what is the histopathological evidence for autoimmune etiology? So, in a skin biopsy, we will see lymphocytic infiltration around the hair follicles, around the hair bulb in the affected skin. It is known as peribulbar lymphocytic infiltrate. The cells in the peribulbar lymphocytic infiltrate are predominantly T lymphocytes. So, this is an evidence of autoimmune etiology. The fourth factor is cell-mediated immunity. So, response of alopecia areata to immunomodulators, which decrease the immune response, supports the immunological hypothesis, and this can be associated with Down syndrome. Now, apart from etiology, what is the pathogenesis? What happens at the uh, hair root level, hair bulb level? So the injury is severest in the center. That is, it leads to the sudden precipitation of a group of hair follicles to shift from anagen to telogen phase. Now towards periphery, there is impaired keratinization and hair shaft breakage occurs in the anagen hair follicles, followed by precipitation into telogen. So anagen hair follicles are converted slowly into telogen. This results in breakage of broken shaft that continues to grow out due to upward movement of the follicles in the telogen phase, known as exclamation mark hair. So this is the pathogenic finding of alopecia areata. Let's see what is exclamatory mark hair. So this is the most important finding seen in alopecia areata. It is a pathognomic feature and it is mainly seen in trichoscopy. So in alopecia areata, exclamation point hairs are found. This often border the new patches of alopecia areata. It is seen around the border of alopecia areata, not seen in other type of alopecia. These hairs indicate that the patch is expanding, that is severity. So we can see in the diagram the epidermis, the sebaceous gland, the pilosebaceous, the hair follicle, and the hair bulb. So the anagen hair is connected to telogen part. Now in less severe injury, follicles enter telogen prematurely and hair is shed as a normal club hair. Least severely affected follicles continue to produce a dystrophic anagen hair. Now, because of this autoinflammatory response, various cytokines are released and they are responsible for the pathogenesis, which are interleukin 1, 2, 5, 6, 16, and interferon gamma. These all will decrease the hair growth eventually. Now, the most important clinical finding of alopecia areata is to identify the patterns. Such patterns are very important because the treatment part depends on the type of pattern of alopecia areata. So there are mainly four commonly seen patterns of alopecia areata. The first and the most common type is the patchy type or the focal loss of alopecia of hair loss. Second pattern is diffuse pattern. Third is ophiacic, and fourth is reticulate. So ophiacis is band pattern hair loss over the scalp in the periphery. Periphery of the part is involved in ophiacis and reticulate. Let's see the diagram. So this one is patchy hair loss. You can see there are around 2 to 3 large patches of hair loss in this most common type. It is also the patchy hair loss, the single oval patchy hair loss with multiple black dots you can see or cadaver hairs along with exclamatory mark heads at the periphery. Now this is the diffuse alopecia areata. We can say there are multiple patchy hair loss seen over the frontal and the crown area, and such types needs to be differentiated from androgenetic alopecia. So trichoscopy is very important. Now this type has bad prognosis, very response poorly to the treatment, needs aggressive treatment. It is known as ophiacic pattern. There is patchy hair loss seen over the periphery. It takes a time to recover in such cases. This is the classical example of ophiacis, peripheral loss of hair seen over the occipital and temporal area. And this is the reticulate type of alopecia areata. There are multiple uh, patches of hair loss forming a reticular network-like pattern. So, after classifying alopecia areata into various patterns, now let's see what are the clinical features of alopecia areata. So, the incidence of alopecia areata is more commonly seen in 5 to 35 years of age. First patch is usually noticed by a relative or a barber. Obviously, because the patient does not come to know about the patchy hair loss, and the sudden loss of hair in a well demarcated localized area is a classical feature. It is a smooth, there is smooth, well defined, round to oval, totally bad or loss of patch, slightly depressed below the surface, being deprived of the volume of hair loss. So it is well defined patchy hair loss. And most common site involved is scalp, 90% of cases, and any area of the body can be involved. So any area indicates that it can involve eyebrows, eyelashes, also the beard area. Alopecia areata of the beard is also commonly seen in the males. Apart from this, if the complete loss of hair is seen over the scalp, face, and the body, it is known as alopecia universalis. Now, in early onset paresthesia, abnormal tingling sensation, or mild erythema at onset can be seen because of inflammatory response. Exclamation of mark is at the margins of new or expanding patch is the characteristic feature of alopecia areata. 2 to 4 millimeter long broken hair, shafts of which reduce progressively in thickness and pigmentation towards the bulb end. It is known as the classical definition of exclamatory marker. Means there is loss of pigmentation and thickness seen over the periphery of the bulb end. Now, frayed end appearance or free end can be seen. Also, hair loss can progress in a circumferential manner. On regrowth, the hair lacks pigment, so it does not affect the white hairs. Now, the telogen hairs can be easily plucked out around the patch, and positive hairful test indicates severity or activity in the patch. Initial patch may regrow in a few months, around 3 to 6 months, and alopecia totalis in 1 to 2% within 2 years of initial patch. So this is the dreadful complication, or you can say that it can lead to alopecia totalis. Now, the occasionally initial hair loss is diffuse. So total denudation of scalp within 48 hours can be seen in children of atopics and Down syndrome patients in 48 hours. Diffuse alopecia areata. So what are the poor prognostic indicators in alopecia areata? This is the most important part of this presentation. So if the patient has early age of onset, like in children's, as early as possible, it is severe. Also, extensive scalp involvement. That is more than 50% of the scalp is involved. It is a poor prognostic indicator. Loss of eyebrows and eyelashes is a bad prognostic sign. Alopecia totalis, that is complete loss of scalp hair, and alopecia universalis, complete loss of hair all over the body. It's a very bad prognostic factor. The patient is getting recurrent episodes after treatment, after getting recovered. Also, the patterns which are very important, like ophiasis, Cissafio, and reticular, have a bad prognostic finding factor. Apart from this, if the patient has nail changes associated with alopecia areata, so it is very important to examine the nails in any patient of alopecia areata. What are the nail changes? There is regular nail pitting is seen. Onychodystrophy, that is complete dystrophy of the nails. Onycholysis, that is breaking of the nails, or separation, and anonychia, the nail changes found in alopecia areata. Pitting is the most common finding seen. Associated systemic disorders like atopy, that is allergic part, hypertension, connective tissue disorders like SLE, and Hashimoto thyroiditis are all bad prognostic finding, autoimmune type. Associated genetic disorders such as Down syndrome is a bad prognostic finding. Also, patchy regrowth of terminal hairs within the patch. Within a patch, if the patient has patchy regrowth of terminal, it's not a good, it's a bad prognostic finding. Family history of alopecia areata and NF173 C gene, that is macrophage migrative inhibitory factor gene. So these all are the bad prognostic indicators in alopecia. So what is the histology of alopecia areata? If we take scalp biopsy and we want to confirm the diagnosis, so what are the findings seen in histology? So in histology, there is follicular lymphocytic infiltration seen around the perivulvar area, accompanied by progression to catagen and telogen phases. After this, the follicle rapidly returns to an anagen and cycle repeats. Because of this, two major morphological changes occur to the hair follicle, that is trichomalacia and miniaturized anagen hair follicles. In late stages of alopecia areata, you will find numerous miniaturized hair follicles, that is nanocytes. Numerous telogen hair follicles. Nanogen is an intermediate stage between villus and terminal anagen hair follicles, and inflammation is absent in long-standing cases. So, what is the differential diagnosis of alopecia areata? It is very important to the differential diagnosis. Patient come with patchy hair loss, we have to rule out other differentials also. That is traumatic alopecia, androgenetic alopecia, commonly confused with diffuse alopecia areata, neonatal alopecia, congenital triangular alopecia seen at presence of birth, sutural alopecia, neoplasm filling the hair follicle like hematoma, alopecia mucinosa, and metastatic breast carcinoma. Breast carcinoma, if the patient has metastasis towards the skull, it can cause alopecia neoplastica. Now, infections like tinea capitis, non-inflammatory tinea capitis, can is a very important close differential. Pyoderma and syphilis, secondary syphilis. Telogen affluent, anagen affluent, folliculitis decalvans, pseudopelladobroca, and systemic illness like lupus hair are the differential diagnosis of alopecia areata. So the last part of today's topic is treatment. What is the main treatment of alopecia? So there is no cure or preventive or permanent treatment for alopecia areata because it's autoimmune and it can recur. So we have to control the progression and disease. So if the treatment is mainly directed towards halting the disease progression. So what are the treatment modalities used in alopecia areata? So it is classified into three types. First is the topical treatment, local treatment. Second is the systemic or oral treatment, and third is the others, that is in other modalities of treatment. So initially, or the first line therapy, that is immunosuppressants. So topically, you have to give immunosuppressants to halt the decrease progress or to decrease the inflammatory response as it is autoimmune. So the topical immunosuppressant used are topical corticosteroids, TCS, with or without occlusion. So topical steroids can be used in the form of lotion, form of creams, and most important or common modality used intralesional corticosteroid (ILS). In intralesional corticosteroids, we usually prefer moderate steroids like triamcinolone, acetonide, nitrogen mustard. So apart from this topical corticosteroids, other topical modalities include contact sensitizers. So it includes SADV, folic acid dibutyl ester, diphenyls, Cipron or DNC. Such chemical agents are strongly contact sensitizers. You have to apply in a very dilute concentration for a short contact of time. A third modality is topical irritants. So these irritants are very important because they help in reducing the inflammatory response. So the agents used in topical irritants are anthralin, phenol, salicylic acid, sulfur, oil of cad, cantharidine, proton oil, and tretinoin. This should be used wisely because it can on long-term application or for long time it can cause irritant dermatitis. So patient needs to be counseled how and when to apply. And among this, salicylic acid is most commonly used. Other modalities are topical, which includes photochemotherapy, that is topical PUVA, psoriasis ultraviolet A, or thermal PUVA. So topical PUVA can be used and thermal PUVA can also be used because UV radiations will cause immunosuppression. Other treatment are cryotherapy, which includes liquid nitrogen, and laser therapy, that is excimer laser 308 nanometer, pulse infrared diode laser 902 nanometer. Now, these are the topical modalities. Apart from the systemic modalities, includes immunosuppressants, that is oral corticosteroids and cyclosporin. Immunomodulators like alifasa, chemotherapy, that is whole body PUVA or fluorescent ultraviolet A therapy, and others include sulfasalazine or intravenous. So the first two are very important, that is oral corticosteroids. In oral corticosteroids, we don't prefer daily dosing, we prefer oral mini pulse steroid, that is giving those 2 days a week for initially for minimum for 3 to 6 months, and it has a wonderful results in alopecia areata, and in also we can give cyclosporin and other drugs in severe cases. Now the other modalities of treatment, the newer systemic therapy which is currently being used in alopecia areata is oral tofacitinib. That is a JAK kinase inhibitor, and it is mainly used in severe alopecia areata, like alopecia totalis, alopecia universalis. So the other modalities of treatment apart from topical and systemic are psychotherapy. In this, it includes hypnotherapy, systemic desensitization, supportive therapy is dermatography, that means scalp micropigmentation is done for cosmetic reasons or hair pieces or wigs. Now, this is the last investigational therapy which has been undergoing investigation but not commonly used, recombinant human bone morphogenic protein and intralesional candida infection. So this concludes today's topic of alopecia areata.